right. Are we ready for this conversation? Yeah. Woo. All righty. So I am your moderator, Dr. Christina Madison, and I am so excited to join you all this morning with this incredible panel of fantastic, fearless leaders. All righty. So I want to go ahead and give a warm welcome to our panelists. I will start at your right, my left, with Dr. Chara Reed. She is the founder of Pharmacist Women Networking Association. Let's give it up for Dr. Reed. Next, we have Nelsa Cruz. She is practice administrator for Patient Advocate. We have Dr. Christy Smith, who is the Vice President of Pharmacy and Payer Strategy for Cencora. You guys might have been familiar with that name. It might be on your lanyards. And last but not least, we have Jasmine Pebenito, CEO and founder of Pebenito Consulting. Alrighty, so we're going to go ahead and dive right in. The first topic is we're going to just kind of set the stage here and really understand healthcare inequities. So I would love for Dr. Reed to go ahead and start us off here. If you could give a brief overview of your background and experience related to healthcare disparities.
Yeah, so I am a pharmacist by training. I started working at the age of 5 in 1993. I was a baby. And so, and when truly I was a teenager, and when you start out working in a pharmacy at that young of an age, you don't really have a concept of any of these things. You have no concept of what it is that you're doing for patients. You're just getting through your day, counting pills, processing insurance claims, not really understanding that everything that you're doing in that pharmacy is serving a patient, is serving someone that's in the healthcare system. And thankfully, I had a love for that and was able to then continue on and go to college and become a pharmacist, because I started to learn that what we did in that pharmacy was important, and it impacted patients' lives. So, that was really my foray into the healthcare system. Not really, I literally decided to go work at Walgreens because I could walk there and I didn't have a car, and I didn't know that decision at that age would absolutely change my life and put me squarely in front of patients. And as you guys probably know, as a pharmacist, we are the most accessible healthcare provider to the community. Can I get a yes? Thank you. So all of those fearless warriors, truly, that are pharmacy techs and pharmacists, and really the supporting teams that support us, because we couldn't do what we did in the community without other roles that supported us. We truly are on the front lines of patient healthcare. So that's really where I got started. And Lord have mercy, I did not know where that journey would take me. I didn't know it would take me here today. I never would have imagined I'd be sitting on a stage talking about health equity, and given what my background was. Thank you.
Yeah, I would love for Nelsa, if you want to go ahead and give a little bit of your background as well.
Is this where I speak Spanish? En español? Did you guys sign up for this en español?
Sí, yes.
Sí. We love our bilingual queens.
Yes.
So, Nilsa Cruz, I am originally from Puerto Rico, and I live in Cheese State, Wisconsin. I've been there over 30 years, and actually, I am the practice administrator at a private, independent rheumatology clinic with 1 rheumatologist and 4 supportive staff, and you're looking at one of them. I started doing this for about 20-some years ago, and quite frankly, I did not ask for this job. I was a former pharma consultant. in the past. But my husband, the rheumatologist I work for, said, you got to come in and help me a little bit. Right. So my position was baptism by fire. And I could never understand why our Latino patient population could not sign up their registration forms. Forgot my glasses, right? We've heard these stories. Because of the patient population that we treat, we have quite a few African Americans, with lupus, many of them non-compliant, and then the remainder. But in the end, guys, do remember, we're all humans. We are all patients. And many years ago, I stopped drinking the journey Kool-Aid. This isn't a journey, this is a battlefield.
All right, Dr. Smith, would you like to follow that?
I'm not sure, but I will try. Good morning, everyone. I'm so happy to be here with you. I am Christy Smith, and I hail originally from Mobile, Alabama. Does anybody in the room represent? Okay, and there we go. But, I tell people I was not born in Texas, but I got there as quickly as I could, and now I'm in Texas. So, all the schools there. What I'll tell you is, like Char said, I never thought the journey of my professional career would take me here today. Growing up in the Deep South, all my family's still there. There are a lot of, I think I would describe it as misunderstandings when it comes to the medical community. And I'm not talking about Tuskegee, y'all, so let's just throw that out. So when I started this professional journey, my family members actually would come to me for help and guidance. And what I have found oftentimes helping them through their different disease states is that they just need someone to break information down in a way that they can understand it. And a lot of times that eventually leads to just helping them ask their physicians the right questions, right? So that they can have better outcomes. And then fast-paced me on to Texas now, and I also participate in another organization called Jack and Jill of America. And okay, got some fans there. And I will tell you, a lot of the women in that organization are very well educated, but just because they are educated does not necessarily mean they are health literate. Okay, so so there's a broad spectrum for healthcare equity. And I think, when asked to be on this panel, I love the idea of just having a conversation on how we all at this Healthcare Advocate Summit can participate in different ways. And sometimes those ways do involve cultural differences. So I am a pharmacist too by trade. I know they're like, why have we got all these pharmacists up here? But I am a pharmacist too by trade. I have my PharmD and an MBA. I say that because I have found myself advocating more on the business side of pharmacy. My role today involves increasing access for community providers in the payer landscape. And so I'm sure there'll be more opportunities to talk about that, and I'll pause there.
Yeah, I love that, communication is so key, and I think oftentimes we forget that, sometimes our patients just need that extra explanation, and so I love that you really focused on that. So now I'd like to turn it to Jasmine. Would you like to tell us a little about your background?
Well, hi, y'all. Thanks for being here. Day 2, a little sleepy, so we're just gonna, get the energy up in this room. Jazz Pebinito. What I really appreciate about coming onto this panel is an opportunity to get back to my roots. So my roots are in public health advocacy, where I was a health outreach worker and a family planner in the LA area. My primary grants were for sex workers and at youth, teenagers, etc. My claim to fame is opening a school-based clinic in LA. Everybody see the movie Grease? Okay, so Grease, Marshall High School, we opened a school-based clinic there in LA so that folks could get competent, quick care, right? Especially sex workers. They can't necessarily go to the doctor, but they can go pick up their kids. So we built a process around that, and I will always, even though I'm now primarily in the biotech pharma space, that is my root, right? My root is doing HIV testing in clubs and then delivering those results in a compliant manner to those who may be affected. So that's where I come from, and I appreciate coming back to that today.
Well, I didn't know how to follow that. The work, the work is never done. The work is never done. And I think you really illustrate that by saying that you have to come back to your roots, right? We all have to come back to that concept that public health and public policy is what's needed to drive meaningful and lasting change. All right, so let's dive into some questions here. Obviously, we know that there are many systemic barriers when it comes to providing health care. I want to go ahead and actually I'm going to go ahead and start with you, Jazz. And really, let's touch on the root causes of healthcare disparities, including any socioeconomic factors, racial, ethnic biases, and structural inequities. And if you could maybe talk about what you think some of those root causes are.
So I have a bit of a bias, right? I think in my roots, from a socioeconomic perspective, that's a big one that I see, and it's hard for me to unsee, right? I also, in my day job, advise clients as well have run foundations, right? The needs-based programs. So again, that's where I see a lot of inequity from a socioeconomic perspective, but also being a daughter of an immigrant, right? An immigrant daughter. I also see from a cultural that there's a pride and a stigma to asking for help or seeking support. So for me, that's definitely where, when I look at those barriers and disparities, that's my bias, but it's also where I draw connection.
And I think that's hugely important, especially when we think about different ethnic groups, because of things like, both current and historical trauma that lead folks to not want to engage in the healthcare system.
Absolutely.
Yeah. So, Chrissy, what are your thoughts about what you think some of the root causes of these inequities are?
I think a lot of it is economic, truly. If you go back from a historical perspective, African Americans are Black people of color, descended from slaves. So if we really want to go back to the root cause for that population, I can't ignore that, because I think for a lot of that population, they did not move ahead. It didn't trickle down to them. Like they weren't able to overcome. So rooted in that, you have food insecurities, education is limited, just in daily living activities. Ownership of housing is important, to know how to live in a community. And so if you're raised in, government housing, back in Alabama, we called it the projects, you may not have access to going to the doctor for regular visits. And you may have also some biases about what the doctor is telling you, because for poor Black people, especially in the Deep South, by the time their family members got to the hospital, they died. So when they got back, so you're saying go to the doctor, where every time one of my loved ones went there, they didn't come back. So you have that mental or emotional component. So, God bless all healthcare providers, because you got all that coming into your practices and your facilities that you're trying to deal with, but also help them improve their healthcare and get to positive outcomes.
Yeah, I couldn't have said that any better. Yeah. Did you want to?
Yeah, I would add to that, to Christy's point. I think that that's true, and I think there is a lot of historical trauma, but I want to make sure that we talk about that there's today trauma. There are people who walk into providers' offices today, and I think that's why there's probably such a need, and I know you guys are in the room, that you are patient advocates, because today sometimes you walk in and for various reasons, you could not be believed on what you are trying to experience or what you are experiencing as a patient. And that, I mean, people make assumptions. I myself, okay, so, I think about my background. My grandfather's grandmother was a slave. My grandfather and my grandmother, they had 19 children. My mom was number 18. She was the only one out of 19 to go to college, right? So I'm a second generation college grad. I have 3 college degrees. And when I took my son, I was 2 weeks postpartum. I had just had my 4th child, and my second child had a seizure, and I'll never forget this. My baby was 2 weeks old, and my 3-year-old was seizing next to me on the bed, and I kind of didn't know what to do. And he ended up in the ER. It was a febrile seizure. But when I went, the lady who walked in to ask me for my insurance, she didn't ask me. This is what she said: "Can I get your Medicaid card?" Right? And not that there's anything wrong with being on Medicaid. There's a we need to have a Medicaid program, right? But there was an automatic assumption, on her part that I didn't have private insurance, and no, when you're 2 weeks postpartum, you don't look like this, right? You're not walking into the ER, glammed up when you just had a baby and it's the middle of the night and you're...
What you talk about?
You might think I go to bed looking like this, but I don't. And so it just, again, being a patient and having that experience, just understand that we have to, for even us, we have to level set that field and understand that there's biases in the system, and how do all of us today think through that, and even think through our own biases, and how do we better take care of patients and throw that away. Throw those biases away and take each person as they come, as a human being, and truly take care of them, So thank you.
Yeah, big lesson there. Believe people. Right?
Am I allowed to add a little
Of
fire
course.
to this heat?
Oh, I was just about to ask you
Go
a
ahead.
question, Miss. My spicy Latina.
So I think the doctor I work for always says, if you're going to bring me problems, you're going to have a solution.
That's right.
I don't want to hear problems. I want to have a solution. So I believe that assumptions, as simple as that, it's really a roadblock for many of the patients that we have in our clinics. My assumption that everyone could read an intake form, boy, what a big mistake I made, right? Mm-hmm. Again, baptism by fire. I'm a Latina, I should know better, right? I don't. So these are all experiences, and one of the things that I have learned, as you stated very eloquently, you really have to treat everyone as an individual.
Right.
Even if they are the same color of skin or the same accent, because you never know what happened before that patient walked into my office. You never know what kind of potential challenges, mental issues, stressors, parking issues getting to my office, because after COVID, there is no longer valet parking in this big, huge hospital institution where we now rent office space. And patients are calling and saying, I cannot make my appointment. Do you think the doctor can do a telehealth or a telephone? Imagine someone who is an expert in actual examination of a patient in order to be able to come up with a diagnosis, right? People that are coming from the underserved areas and are not able to find a parking spot. What a roadblock that is.
And not even just not being able to find a parking spot, but maybe even not even having transportation to begin with.
Exactly.
Right? And we see folks being penalized, right? You're 10 minutes late for your appointment. Now you're being charged because you had to take a second bus to get there, and that bus was late, and now you're being penalized and charged.
So the
Right, on top
solution
of it.
is we're moving.
Good job. Yeah.
That's the solution.
For you.
Yeah. It sounds like you really took to heart what that physician
Very
said to
hard,
you.
because I have to recredential everything and give a new address to every, BOCA payer out there. It's very difficult, administratively speaking. Yes,
It's hard to have.
but we have to do it.
It's hard to have a successful practice if your patients can't get to you, right? So, yeah. So I know we've talked about some problems with the system, but I'm curious if we could maybe talk a little bit about some solutions at this point, and maybe talk about some strategies for fostering compassionate care and understanding. And if you guys could give some examples of some successful initiatives or programs that you feel have been able to reduce some of these health disparities. So,
Can I?
Nellie, so you want to go ahead and start?
Sure. Remember that I was a former pharma consultant. So, of course, I do have pharma reps coming to the office. And when you're launching a new product, you're really excited, especially one that saves lives or spares a patient from disability. You are so excited to launch with whatever you got after FDA approval. And then they come to my office and they have these beautiful sales aids and patient brochures, right? And they're all in English. And 1/3 of my patient population is in Spanish, Latina, right? Latinos. And I say, where are the Spanish speaking, the Spanish brochures? We needed to launch, and this is how we start. And I can give you an example and I will mention the company because actually they came through for us. Teva, or Tiva, right? Yeah. Teva in español. So when Teva first came out with their biosimilar for rituximab, it was really exciting, actually, but there were no Spanish brochures. So the rep was able to put us in contact with Up, and they had meetings, and very shortly after that, they came up with those Spanish brochures, and I remember distinctively my wonderful rep saying, "This is because of you." Wasn't that amazing?
That's amazing.
Yeah.
That's incredible.
Another thing that I would like to point out is, again, because my hands are into administration at our clinic, 5 people total, patient assistance programs. Have you all seen those applications for the different companies? In the end is a patient name and then patient signature. Let that sink in. Signature, right? I have patients that do not sign cursive. because they have a really difficult time reading and being able to write. And I literally had one pharma company turning down an application for insurance verification, which also would enroll a patient in copay card and or PAP program, because the signature was not in cursive. So I had to explain, and this happened this year, I had to explain to the company that my patient was illiterate in order for them to process the app. So this is a call for help. If there are any pharma companies here, any advocates in close contact with them, have them relook at those patient applications, and let's make a positive change.
Oh, that's good.
Did you want to
Yeah,
add to the conversation
yeah,
there?
let me jump in here. So I'm going to pivot a little bit and give you a perspective from our community providers, and not just community, but also health system providers, right? So one of the things that we were tasked to do on behalf of community oncology specifically was to help those independent community oncologists out in the community practicing be able to service their patient from diagnosis to dispensing. Okay? And, you know, going back in time, I've been practicing for 30 years. You know, there were only a couple of drugs available orally, Timodar and Xylota. Those were the two I remember. But now there's so many products that are so much more advanced that can save patient lives. And so physicians have started to dispense those drugs in office. The challenge was that the payers, the PBMs, the health plans, did not always allow access to the community. Now let me tell you the value prop of why it does make a difference in the life of a cancer patient, because the pharmacist dispensing the drug is a part of the healthcare team, number one. Number two, she can see real time the EMR at the same time as the pharmacy record. So she's not going to dispense, I only know brand names, so I'm just picking one, pharma people. I love y'all, all the products. So she's not going to dispense Imbruvica, for example, if she can see the scan and can see that the patient is not responding, right? The challenge with other types of specialty pharmacies is that the physician, doesn't always communicate that. So that drug could still go out based on the last order. And so what we found is a payer willing to partner with Cencora to give their physicians access to all of their own patients. And that has really been a game changer for the patient and for the practice, because community practices, especially specialty practices, are struggling to keep their doors open. They need additional revenue sources in order to treat patients. And that is not just in oncology. It also applies to rheumatology, asthma, allergy, gastroenterology, all the specialties. And so that's one of the programs that we were able to launch and drove this year, I think 2023, $89 million in new revenues to 80 practices. That's quite a bit. So the physician can offer more services, right? Because now they have an additional revenue source that does not just sit on the buy and bill or the medical platform.
One thing I just wanted to say about this example that I absolutely love is that sometimes things that might be good for the business is also good for the patient. Because now you've taken away a barrier to care and potentially added another healthcare professional that can make sure that they're getting the right drug at the right time, the right way, and from a pharmacoeconomic standpoint, it's cost savings to the insurance side, right? But then it's also impactful for the practice because they're going to be able to directly dispense to the patient and make sure that that person doesn't have an extra step that's needed before they get drug in hand.
Yes, especially when you're dealing with a cancer,
I mean,
a life threat. I mean, just the stress of that alone, you know, you want to get started on therapy. Or in rheumatology, for example, you know, just the disabilities, the pain, you want immediate relief, and that's another good point for
Exactly.
access. You know, you can
I
get
was
it-
going to say patient compliance. Look, guys, beyond and above the financial aspect of any of these, because when you do the right things, little step at a time, right, the financial will take care of it. Word of mouth is very powerful.
Yeah.
But when you're actually dealing with the patient and you're, you know, not worrying about the money part, but worry about your patient, having those kind of services truly increases compliance.
Yes, and
Because-
actually, we have a study that we did on this data, and we showed that it did increase adherence.
Absolutely,
And it
especially
decreased the cost of care. So don't forget it.
That's
it
what
actually
yeah.
decreased the cost
And
of
that's
care.
the
I'll let you-
total cost
Yes.
of care, total,
Yes.
not just on the pharmacy side, but on the medical side combined. And the payer themselves published the data. They were so proud. So plan sponsors who actually pay the PBMs or health plans are signing up like crazy for this program. Now, it's just Blue Cross Blue Shield, and it's 18 plans that participate, but I'm doing all that I can to publish more data because payers believe data. And so if a patient is being treated by a specialty provider that has a pharmacy inside their practice, give them access.
Yes.
it is also one less stressor for the patient, because if you think about it, if they live with a script, now they're going to start dealing with the shenanigans of the BUCAs, Blue Cross, United, Cigna, Aetna, Humana, and or the PBMs. And that is very, very stressful. We're all advocates here. You know, if there wasn't a problem, there would be no need for us.
This conference would not need to exist. Okay, Jazz, I know you got something to say.
Oh, so much. So I guess I don't have the answers, right? But I can say from my seat, when I'm opining with my marketing colleagues, right, it's getting back to the root. It's to say, yes, but if a life-changing, right, so close your eyes for a moment, you're walking into the office, you're getting some life-changing news, how do we want to show up, right? So those of y'all in my session this morning, I'm an abstract thinker, right? So I'm always thinking about vision and feel in that aspect. So when I think about strategies of how do I want a patient to feel that they are safe, that they can trust, and they can count on my programs to be there for them. So how do we do that? So by partnering with folks to make sure that our programs are accessible, that there is awareness. And when I find specifically a strategy that we're employing in biotech pharma is this pivot towards more partnership with advocacy. I think we have a great voice, right? And I think where I've challenged my peers to say, we do not have to be the doing, right? There is an army of people out here who can do for us if we just take the moment to cast the net, provide resources and education, and we can exponentially put our efforts out on the street, right? Again, health outreach worker, right? Feet on the street is my jam. So that is where, for me, as much as we can do that, I try to push that in the boardroom.
And I think First of all, I think it's incredible, our panel, all coming from these different backgrounds. Christy with payer partnerships with the distributor, Nilsa directly in the practice, you as consulting with pharma companies. But I think I want to add that the charge really for all of us is how do we even get to those conversations? And I think part of that, and we have to think through, there's a lot of us in the room here who work in systems or for organizations. How do we hire a diverse team to give diversity of thought because they have diverse backgrounds and are looking at things from different perspectives, right? And so the reason that your company, that drug company, that marketing team probably didn't think about a Spanish brochure is I'm betting there wasn't a Spanish person on the team, right? And so a lot of times you don't get to these problems when you, if in fact you have a mindset to hire diverse team members, to not hire everyone who has your same background and that looks like you, right? And so that's probably even maybe an elephant in the room that we sometimes fail to discuss or talk about, that we don't get to some of these things. These things wouldn't necessarily be problems if we had diverse perspectives at the table when we're making these sorts of decisions that ultimately affect our patient population, who, by the way, are diverse.
Yeah.
Can I add to that? So here's a specific tactic for my peers in the room or who are at these large plan of action committees, right, where we're talking about deals with payers, et cetera. I'm there to consume that information. I do not influence it. But where I hear my account team who focuses on the prison system, right, as a major account. What folks heard was there was a problem with the discounting, right? Those of you who understand pricing. What I heard was that the community or the practice within the prison had a problem with losing patients going out into community upon release. So that's what I heard. I was like, discount all you want, whatever. But what I heard was I need to stand up a team versed in the journey from prison release to halfway home, to their home, their halfway housing, and then to their next visit for cure and prevention. So I stood up a team that understood the journey from prison, in prison, to release, to their first visit in community practice. So to your point, right, I heard something different. I'm always in the room listening for something different, but I stood that team up, right, to be experts for our prison community.
I love this example as somebody who has also done a lot of work in the reentry space and carceral system, because public health, I'm public health pharmacist. I know that carceral health is a huge component of public health, and what I hear both of you guys saying is the importance and the vitalizing nature of having folks with different lived experiences. And one thing I say all the time, I say nothing about us without us. Nothing about us without us. So if I am commenting on another race or ethnic group's health disparities, social determinants of health, how am I coming at that if I don't have that person's lived experience, right? And so we need to have those more diverse voices in the room. Otherwise, we are not going to be able to move the needle. Which leads me to my next and final question for the group, which is policy change. So policy and advocacy go hand in hand, because we know when we don't have the policy, it's very difficult to advocate. So if you guys can talk about, you know, what some of the current policies are that may be impacting these health inequities and how we can move the needle forward. Do you want to start, Chara?
Sure, yeah. One of the things we're experiencing right now, and I don't remember the bill, unfortunately, but right now, part of the Sunshine Act states that the interpretation of the Sunshine Act is that a physician who owns their own pharmacy if they're taking care of a state-funded or federally funded patient, which is i.e. Medicare patient, they are not allowed to ship that medication to the patient. The patient has to come to that practice to pick up every single prescription refill. Think about what that means for a patient who has cancer, or their caretakers who have cancer, and they cannot come, they are not allowed to be at home and get a delivery sent directly to their home because the physician owns the pharmacy. Now, they can get a mail order shipment from any place else, but not from their provider's office. That needs a policy change. There is a bill right now in Congress to change that policy because you are tying the hands of our community physician providers, and we support at Cencora. We have an office on the Hill, and we bring physicians to talk to congressional people in Congress to talk through. This is not about the doctor making more money. This is about a patient who can't receive care, right? And that needs to change.
Yeah, that barrier is ridiculous.
Yeah.
I do not know if there's a bill for this or not. All I know is that many of my Medicaid patients, as of July, lost their Medicaid. And we're not alone. I think how many millions in the country? Millions in the United States. We're struggling because some of these patients are able to go into the ACA and get some insurance there, but many are literally going uninsured. And that is putting an additional administrative strain for people of 5, right, at a clinic, where I'm the one doing all of these PAP applications and whatnot, in order to be able to continue to keep them on treatment. It's like a domino effect for some reason, and someone just pushed the wrong domino, and my patients are just falling through the cracks.
Yeah, there were several changes in legislation, things that fell off post-COVID when they expanded the Medicaid expansion and lowered the threshold for qualification. And so you're right, there's a ton of people who just woke up one day and didn't have coverage, right? So how do we fix that? Well, first is that we need to point out the problem. And then next is we need to be partnering with private and public institutions to be able to facilitate getting them alternatives to that coverage, or to have somebody sit and go through and help them navigate the process of reapplying. And that's part of the issue too, right? Because they make it so difficult.
The letters that they get are not simple.
Yeah, they make
they
so
get them
difficult.
and I say, can you just text those to me so I can read them? They cannot understand the letters that they're getting from the state.
Yeah.
And I would just jump in and say, for those states that refuse to accept the federally funded Medicaid expansion, right, like Texas, like Alabama, just 2 states that I know personally, and I would just say there, you can advocate anywhere that you are. I advocate at work, for different issues that are meaningful, and I think we have to do our part in advocating for that level of change in your individual home states.
I just wanted to just really say thank you for your perspective, and I do think that because we all come from diverse backgrounds, ethnic, different areas of the country, different upbringings, I think it really does illustrate that it does take those diverse voices in order to come up with solutions. So, for me, if I can kind of summarize what this panel has done, is we need to understand that everybody who's coming to a healthcare facility is going to have some type of adverse experience that leads them to have a potential negative experience at the healthcare access point. And we can overcome those inequities and barriers by making sure that we are allowing those people to come as their authentic selves. And then on top of that, we need to have policy change in order to facilitate and to enshrine these safeguards so that folks don't fall through the cracks. That's what I'm hearing from you all. And before we end, I just wanted to get, what is your call to action for our audience today? What can the folks here that are listening to this very important conversation take home with them in order to make meaningful change in their communities?
Hug your patient.
Oh.
I love that. Get active, partner with people who already have the pathways built out to legislate and to advocate through legislation. There's lots of different ways. Your distributors are doing it, your pharma companies are doing it, your organizations like this are doing it. There are a lot of organizations, you don't have to recreate the wheel. You can partner with them to help get our legislators to understand we need change to positively impact the outcomes of our patients.
And I just add to that, and advocate where you are. Advocate now where you are. I love seeing all of the different advocates in the room at this conference, and it's just very inspiring. So we can all advocate exactly where we are.
Yeah, kudos there. Advocate where you are. I would even bring it down even more tactically to the payer level, right? When we see contradicting policies on getting patients life-saving treatment, for example, for something that's a cure, and then we see a sobriety policy, like two different things, right? I'm not treating the addiction, I'm treating the disease, right? A different type of disease. When I see obesity policies versus, again, I'm trying to treat a liver disease, I'm not trying to treat the other part of obesity, right? So trying to get folks to compartmentalize, and that's y'all. It is hard, but keep going. Your strength in numbers is what moves that needle where you are, right? And then that trickles up. Right, we are in a bottoms-up, powerful position, right? Don't wait for the top down. We ain't got time for that. Ain't nobody got time for that. So from a bottoms-up powerhouse, right, we are the foundation. So I beg you for my future potential grandchildren and my children and me, because I'm ready to retire, y'all. Me too. I'm ready.
Yes. And I'll end with this from my perspective. Think about the starfish, right? If you guys have ever heard the starfish story, the child throwing all the starfishes back into the sea. Remember that for that one starfish that you help get back in the water, it means everything, right? So don't think that the one person that you're talking to or the two patients that you end up impacting, that it's not making a difference, because it does. Because when they have a positive experience in the healthcare system, it forms a ripple effect. And then they're going to talk about it with their family, their friends, their communities. And we know that that's how people make healthcare decisions. It's not necessarily from their pharmacist or their physician or their nurse practitioner or their community health worker. It's from their social circle. So when they have a positive experience and they tell others, that means that those folks are going to come and get a positive experience as well. So just one person, it means the world to them.